Okay, so what is the aphakia? Aphakia simply meaning that it is the absence of the crystalline lens. And what is the problem of absence of the crystalline lens? This is a huge problem because we said that the crystalline lens act as one of the second major refracting surface of the eye. So absence of the lens will cause high hypermetropia and loss of the accommodation. So these patients will have loss of accommodation because of loss of action of the lens, and will complain from severe hypermetropia. What will make aphakia, or what will make the lens absent? It can be either congenital, although it is rare, but it can occur, absence of the crystalline lens, or usually, or the most common reason is surgical aphakia after cataract extraction. So we removed the lens and we didn't put any intraocular lens. Post-traumatic absorption of the lens, which occurs frequently with the trauma, so the lens will absorb, or it can even extrude outside the eye, or posterior dislocation of the lens after trauma. What we need to know is what are the optics of aphakic eye. So we have just mentioned that there will be high hypermetropia. So what else? What are the characters of aphakic eye? Apart from the high hypermetropia, the total power of the eye is reduced to plus 44. So there is only the corneal power, while the 17 or the 18 diopters of the lens are lost. They are no longer present. Also, the aphakic eyes consist of a curved surface, which is the cornea, separating two media of different refractive indices, which is air and aqueous and vitreous. So instead of having different refracting surfaces, so we have the air, then we have the cornea, then we have the aqueous, then we have the lens, then we have the vitreous. The optics has changed. So we have only the air, then the cornea, then the aqueous and the vitreous, which have the same refractive index. So this also will have its consequences over the optics of the aphakic eye. The anterior focal point becomes 24 millimeters in front of the anterior surface of the cornea. So this will be the focal plane or anterior focal point of only the cornea without any consideration of the lens. The posterior focal point will become 32 millimeters behind the anterior surface of the cornea. So this will be only the focal point of the posterior focal plane of the cornea, regardless of the lens, and there will be total loss of accommodation. So let's just summarize some of the data that we have already mentioned before in the previous lecture, and we will see how can we use this data to know what will be the amount of optical correction of aphakia. So we said that the eyes will become highly hypermetropic. This will be the condition if the eye was previously immetrope. But for example, if the eye was previously minus 15 or minus 20, then this myopia will be compensated by the hypermetropia. So unless the eye is highly myopic, the eye will be highly hypermetropic after aphakia. So we will just all our examples, we will consider that the eye is immetropic. So after aphakia, it will will suffer from severe hypermetropia. So in case of hypermetropia, as we mentioned, the punctum remotum will be a virtual point behind the retina. So the power of the cornea or power of the eye will be the power of the cornea only, which will be around 42 diopters. So if we have the cornea is only the refracting surface, the F1 will be situated at 24 millimeters, F2 will be at 32 millimeters, and the nodal point will be 20 millimeters in front of the retina. So how did we reach this conclusion? This is by the formulas that we used in the first lecture. So by using the power equals N1 minus N2 divided over the radius of curvature, we said that the anterior corneal surface has a power of 48 diopters, posterior corneal surface has a power of minus 5 diopters, so the net power of the cornea will be equal 42 diopters. So, and the F also can be concluded from this formula. So we said that the F1 of the cornea is 24 millimeters. F2 of the cornea is 32 millimeters, and the F1 is not equal to F2 because of different media of both sides. So in front of the cornea will be air, and behind the cornea will be the aqueous and vitreous. And by use of the Newton formula, the compound homocentric system that we mentioned in the last lecture, we said that if we have a compound homocentric system in which there are different refractive indices or different media in front of each other that are centered on common axis, then they will have 6 cardinal points, F1, F2, P1, P2, N1, and N2, and we have an object that will form an image. And then this object will form a parallel ray, will be passing through this system and will pass into F2. And then we have a line or a line passing through the F1 will pass through the system parallel, and then it will emerge parallel. And then if any ray passing through the nodal point, N1 will pass through the N2 and will emerge, so they will form an image. And by the basic trigonometry or by calculation of the different of the since this angle and this angle are similar angle, and this angle and this angle are similar angle, so the object size over the image size, which will be the same like I dash, will be equal to the L1 F1 L1 to F1, and will be equal to F2 L2. So O over I will be equal L1 over F1, O dash over I will be equal to F2 L2. So the Newton formula, meaning that the object size over the image size will be equal L1 divided by F1 will equal F2 L2. So by F1 by F and F we meaning that this is the focal length, and by L we meaning that the distance between the object and the focus, and this L1, while the L2 is the distance between the image and the focus. So Newton formula state that the L1 L2 equals F1 F2. So L1 L2 equals F1 F2. This is called the Newton formula that we mentioned in the last lecture. So how to calculate the power of correcting lens in case of aphakia? So we have here a eye. This eye has only the cornea as a refracting surface and has a nodal point which is situated 20 millimeters behind the anterior corneal surface. So in case of hypermetropia or in case of aphakia, the eye becomes highly hypermetropic, so that if we have an image or present at the retina, or a point present at the retina, will emerge light rays which become divergent outside the eye. The extension of these light rays will come to a point behind the eye which is called the punctum remotum, and this has been also, we said that in the hypermetropia. So the punctum remotum will be a virtual point behind the eye. So this will be the F1 of the cornea, and this will be the F2 of the cornea. So note that it is located behind the eye since it is large or tall, as we said. The F1 will equal 24 millimeters, and the F2 will be 32 millimeters. So how to calculate the power of the correcting lens? To calculate the power of the correcting lens, we assume that there is an object present at the punctum remotum, and its image lie on the retina. So if we in such condition we can apply the Newton formula. So in Newton formula state that L1 L2 equals F1 F2. So what is L1? L1 is the distance of the object or the punctum remotum from the F1. So L1 here will be the distance of the punctum remotum to the object which is present at the F1. L2 will be the distance of the image present on the retina from the F2, which will be equal 8 millimeter. This is 8 millimeter, and this is why, because we know that the normal emmetropic eye will be 24 millimeters from the Donder's reduced eye and the schematic eye, and in case of f2, in the case of the cornea as a refracting surface only, so the f2 will equal 32 millimeter. So f2 in such condition will be, or in such a condition in which there is aphakia, the f2 will be 32 millimeters. While in the while the f2 was on the, when the f2 was on the retina in case of normal eye, the f2 will be equal 24 millimeters. So the distance between the f2 while it was on the retina and the f2 when it is behind the retina will be equal f2, which is 32, minus 24, then this distance will be 8 millimeter. f1 will be equal 24 millimeters, and f2 here will be 32 millimeters. So by applying the Newton formula, L1, L2 equals F1, F2, then L1, which is the distance of the object from the F1. So here we will put the correcting lens at the F1, and we need to know the distance of the or the focal length of this lens, as the focal length should be coinciding with the punctum remotum. As we said that in case of ametropia, to correct any ametropia, the f1 of the lens should be coinciding, or the focal length of the lens should be coinciding with the punctum remotum. So here is, we need to know what is L1. So since we have L2 and we have f1 and f2, we can know exactly how is the L1. So L1 will be equal 96 millimeters. So it will be 24 multiplied by 32 divided over 8. So the length of the focal length present in the anterior focal plane, or the f1, that is needed to correct this ametropia will be about 1 meter. So the 96 millimeter is the focal length of required correcting lens present at the f1 at the distance of 24 millimeters. I hope that this proof is clear. So again, we need to put a plus lens that has a focal length of 96 millimeters that is placed at the distance of 24 millimeters at the f1. So as we said, the optical principle of correction of any ametropia is to locate the far point, to choose the lens at which the focal point coincide with the punctum remotum. So we aim of the correction is to bring the punctum remotum at the infinity by a convex lens with its focal length coincide with the punctum remotum of the aphakic eye. So here, the same example, we need to put a lens here. This lens is present at the f1 at a location of 24 millimeters. If we put a lens here at a distance of 24 millimeters from the eye with its focal length 96 millimeters, then this light rays will bring, or this lens will bring the light rays at a focus at the punctum remotum, so it will correct the ametropia. So if a lens is placed at the f1, which is 24 millimeters from the cornea, then the power or the focal length should be 96 millimeters. So it will be around 1 meter, and that's why the power of the lens will be 1 over 10 or 1 over 0.1 meter, then it will be equal 10.4 diopters. So we need to put a lens which has a power of 10.4 diopters in the f1, which is 24 millimeters. But does we do this? So if a patient has aphakia, do we put a lens that is present about 2 centimeters and a half in front of his eyes? So the answer is no. But we put the lens in the spectacle plane. So if we wanted to change into the spectacle plane, if we wanted to put a lens in the spectacle plane which is further more close to the eye than the f1, how can we do this? In such a condition, the f will change. So the focal length of the lens will be changed. So it will be 96 minus 11. So minus 11, how can we get this 11? Because 24 minus 13, it will be 11. So we need to move the lens about 11 millimeters in order to reach the spectacle plane, in which the back vertex distance will be about only 13 millimeters. So 13 and 11 will be equal 24 millimeters. And to correct the power of this correcting lens, so we have the usual rule, which is 1 divided over f minus back vertex distance. And here the back vertex distance will be in the plus value because we moved from the f toward the from left to right, which will be the same direction of light rays. So it will be 1 over 0.085. So the lens power will increase. It will be 11.7 instead of 10.4 in when the lens was placed in the f1. So this will be the power of the correcting lens when it is placed further toward the spectacle plane. So what will be the condition if we move the lens further forward? So it will be placed in front of the cornea, like a contact lens. If we change to as a spectacle lens form, then we need to use the rule of the dioptric power of the contact lens equals the dioptric power of spectacle divided over 1 minus the back vertex distance multiplied by the dioptric power of the spectacle. So the power of the used spectacle was 11.7, and 1 minus d multiplied by the power will be equal 0.84. So the power of the contact lens will be 13.8 diopters. So as you can see that the power has been increasing from the f1 to the spectacle plane to the contact lens. So what do you expect if we change that correction into an intraocular lens? Will it increase or decrease? Can you tell me? No answer? Yes, exactly. It will increase. So if we move the lens further toward the eye, so the focal length will be 96 minus 24 millimeters, which is the focal length or the first focal length, minus 4. And what is this for? It will be simply the anterior chamber depth. So we return the IOL more backward to be in the bag. So this will be the anterior chamber depth. So the focal length here will be 68 millimeters. So the power of the intraocular lens will be 1 divided by f, or the focal length. So it is 1 over 0.68 or 0.068. So it will be 4.5 diopters. So this will be the power of the correcting intraocular lens to be implanted inside the eye. So as you can see, as we go further toward the eye, the power of correction increase in order to reach the same retinal image size. So are all these alternatives have the same quality of vision and have the same magnification? The answer is no. So if we have a patient who have unilateral aphakia, and now we need to correct this patient, what will be the effect of different modalities of correction on this patient? The first, if we correct with a spectacle, the relative spectacle magnification will be 1.3, meaning that the difference between the retinal images, the image size using the spectacle and the emmetropic image size will change by about 30%. So this patient will have increase of the retinal image size, or this eye, the aphakic eye with the spectacle, will see the object larger by 30%. And this will lead to anisoconia. And anisoconia meaning that there will be a difference in retinal image size between both eyes. This anisoconia will result in diplopia. So can we correct with the contact lens? Well, the contact lens will be a better solution. because the relative spectacle magnification of the contact lens will be 1.1. So the contact lens will only increase the retinal image size by about 10%. So there will be little difference between both eyes in case of unilateral aphakia. The best solution here will be the intraocular lens, because in the intraocular lens, the relative spectacle magnification will be 1. So there will be no difference in the retinal image size between both eyes. So this will be the best to achieve binocularity. That's why when we do a cataract extraction in a patient and we implant intraocular lens, the patient doesn't report that there is difference in the image size or there is no diplopia, because the intraocular lens is the closest to the nodal point and it has the better or the best relative spectacle magnification. The fourth problem that occurred with unilateral aphakia is called anisoconia, or when we correct the unilateral aphakia, the fourth modality of correction of unilateral aphakia will be the anisoconic lens. Anisoconic lens or a focal lens, these are parallel plate of glass that cause the magnification but with no refractive power. So when the eye is looking to an object, this will be making a visual angle of this ratio. However, if we put a parallel plate of glass, this glass has no refractive power, so it will not cause any changes in the refraction, but it will cause only magnification. So it will see a magnified virtual image to the target because it will increase the angle subtended at the eye. Sometimes, or in the old ages, they used this focal lens to increase the magnification in front of the hypermetropic eye, because the eye with aphakia sees small images because this eye has severe hypermetropia, and we said that the uncorrected hypermetropic eye will see small images. So they used to do an isoconic lens to put it in front of this hypermetropic eye, so in order to increase the magnification. However, they have some disadvantages, that they will show insufficient magnification, about only 5%, and the eye expensive and thick and heavy. So these are widely substituted by the contact lens and the intraocular lenses. So as we said, that the parallel rays will come to a focus behind the retina, and the retinal image size is smaller in the uncorrected hypermetropia than the emmetropia. So patients with aphakia see the images smaller, but when they are corrected, they see the image larger, because the image or the correction is placed in either inside the F1 or as a spectacle plane, or as a contact lens, or as intraocular lens. So they will be closer than the F1. That's why they are seen larger. The fifth solution to correct the emmetropia of hypermetropia caused by the aphakia is by refractive procedure. They are all the procedures that used to the cornea, to shape the cornea in order to correct the refractive power. So this can be done before the era of intraocular lenses. So they use some procedures like keratophakia or epikeratophakia or keratomiliosis in order to shape the cornea, or to add a host cornea to increase the dioptric power of the cornea in order to correct the refractive error, but on the cornea side, not to replace the lens side. This is not of much importance nowadays. Finally, let's come to the optical problems of aphakia. We have mentioned some of these problems. So the patient will have high hypermetropia, and also they will have astigmatism against the rule. And why is this? This is because of effect of corneal surgery leading to fibrosis of the corneal wound, leading to flattening of the vertical meridian. This is assuming that the aphakia is surgical, caused by cataract extraction. So, for example, if we have here a lens and we remove this lens from a vertical incision, fibrosis of this incision will cause flattening of the vertical meridian, leading to that the horizontal meridian will be more curved, leading to against the rule astigmatism. There will be lost accommodation, so this patient will need reading glasses. There will be anisometropia and anisoconia in unilateral cases. As we said, there will be difference in retinal image size between both eyes, which is called anisoconia. This will be around 30%, leading to that this patient will lose binocular vision. So it is better to use the intraocular lens, as it only have magnification of about 2 to 4%, so the relative spectacle magnification will be around 1, or to use a contact lens, as they cause 10% magnification, so the relative spectacle magnification will be 1.1, or use an isoconic or a focal lens, but they are not used anymore. So these are problems that occurs due to aphakia itself, but there are problems with spectacle correction. So when we correct the patient with aphakia with a spectacle, these spectacles can cause some problems. So what are these problems? So, and this will be the last part of our lecture. The first problem will be, as we said, magnification. As we said, the spectacles will cause magnification of about 30%. So the relative spectacle magnification will be 1.3. And this can have different explanations. The first one is that the eye now is acting as a Galilean telescope, and this, let's just postpone this point until we discuss the Galilean telescope. But just to mention, or just to summarize, that the eye will act as a Galilean telescope that has a minus lens and a plus lens. And if we have a system that has a minus lens and a plus lens, this can result in magnification. This magnification will be calculated on the base of the power of eyepiece divided by the power of handpiece. And in such condition of aphakia, the minus lens will be 15 and the plus lens will be the 12, which is the spectacle lens. So the magnification will be 1.25 or 1.3, which will be the same as relative spectacle magnification. Or according to the f1, so if we have the planes placed at the f1, then the magnification will be equal the focal length in the aphakic divided by the focal length in phakic. So it will be 24 divided by 27, then it will be again 1.3. Or according to the nodal point, the magnification will be distance of the nodal point from the retina in aphakic divided by the distance in the phakic will be again 20 over 15, which will be 1.5. So there are just different explanations for the same issue, which is the magnification, and all they will give close or close results to each other. So here we have the model or the scheme for explaining the magnification. It can be that can explain the magnification of the retinal image size using the spectacles, and also from the reduced donder's eye. So it can be divided. It can be used either the Galilean telescope or the focal length, and the f1 here will be 24 divided over the focal length here, which will be 17. So it will be about 1.25. So what will be the effect of this magnification? First thing, that the patient will misjudge the distance because the objects appear closer due to larger angle subtended at the eye. So what will make us judge the distance correctly is that we see the object at the same or of the appropriate size. But if we see that the object appear larger, we will think that the object appear closer. So if we have an object here, and we can, this object will make an angle which is at the nodal point, which is the angle of magnification, and stimulate a certain number of photoreceptors. But if we put a plus lens, like a spectacle correction in case of aphakia, this will leading to a virtual image. This virtual image will be smaller than the object size, but will subtend a larger angle at the nodal point. This will lead to larger retinal stimulation, causing larger image. So this will lead to that the patient will misjudge the object distance because of larger size. So this also lead to difficult hand-to-eye coordination. The only function that will improve at the patient with aphakia is improving of the visual acuity. So for example, if the patient can see 6:9 with glasses and can see 6:12 with the contact lens, and this is a very common question in the exam. They say all these characters occur in aphakia except. So they say that these patients will have a poor performance on the visual acuity, and you think, okay, it is logic because the patient has aphakia, but you forgot that the patient has aphakia that is corrected by spectacles, and the spectacles cause more magnification than contact lens, so they will cause more large size of the visual acuity test, and they will perform better on the visual acuity test. So this will be the only function that's improved. But other than, the patient will have also anisoconia or different retinal image size that can be corrected by a contact lens or intraocular lens, as we said. Also, the patient will have a problem called image distortion. Image distortion meaning that the patient will have the unequal magnification between the center and the periphery of the lens. Image distortion occur in the high error lens, like high plus lens or high minus lens. So in such conditions, when the light rays enter the center, there will be difference in the refraction between the light rays enter in the center and in the periphery. So there will be a prismatic effect of the lens periphery, as we said earlier, of the periphery of the plus lens and the minus lens. And this prismatic effect will cause distortion of the lens. So it will cause distortion of the image. This distortion can be called a pincushion distortion. As you can see here, this is a pincushion distortion, which will occur with the plus lens. Or it can be a barrel distortion, as you can see here, which is like a fish eye in the if you are concerned with photography, this is a lens called fish eye. The barrel distortion is the same like a fish eye. So the barrel distortion occur with high minus lens. So this distortion occurs due to the distortion caused by the periphery of a thick lens in case of high power lens. So how to correct this? Optical solution, ask the patient to look at the axial zone of the lens, not to look from the periphery in order to avoid this distortion. So here is what's called the pincushion distortion. And here is the barrel distortion, and this is the pincushion distortion, and this is the correct vision. So here is the image that is seen from the periphery by a patient wearing large minus lens, and here is the image seen by the periphery of patient wearing a high plus lens in case of aphakia, and here is the normal vision. The third problem that occur with a spectacle correction in case of aphakia is a visual field limitation. Visual field limitation meaning that the patient has a ring scotoma. So ring scotoma meaning that it is again due to prismatic effect of the lens periphery. So ring scotoma meaning that while the patient, this is the visual field of the patient will not be able to see the periphery of his visual field. So all these area that make a ring around the central vision is not seen by the patient. And why does this occur? This is because, again, of the prismatic effect, meaning that if the patient is looking at an object present at the periphery, it will undergo deviation by the prismatic effect by the plus lens. So the image will be deviated toward the base, so that its extension will falling outside the visual limits of the patient. So the patient will not be able to see an image present at the periphery. Another problems occurs, or another visual field limitation that occurs in patients with aphakia is called the roving ring scotoma. Roving ring scotoma is again due to the prismatic effect of the edge of the lens. So suppose that this is a patient with aphakia and he is looking to a target through the paraaxial portion of the lens, so that the light rays undergo deviation by the prismatic effect of the lens toward the base, so that the patient can see now an image of this object at the near the apex. So the eye will move to the apex. But while the eye is moving toward the apex of the prism like this, what happens here? While the lens is placed in front of the eye, the lens, now the object is present at the lens periphery, at the far periphery, so it undergo much more larger deviation. And in such condition, the patient will not be appreciate the presence of the image. So the image will disappear. So sometimes the patient looking in front of him and he will see an object. When he tries to locate this object and move his eyes toward this object disappear, and this is what is called the jack-in-the-box phenomenon. Jack-in-the-box is a toy that while that is when you close the toy and you open, sometimes it's open suddenly, so it suddenly appear and suddenly disappear. So how can we correct this problem? This can be done by a full field aspheric lens. We will talk about this later on. So to manufacture a lens with a more flattening of the periphery to avoid the prismatic effect, or to make a lens with less curved periphery to avoid the prismatic effect. Other problems with aphakia, like oblique astigmatism, this occurs while the patient is looking at the periphery due to eccentric viewing. The periphery of the lens acts as a prism and also can cause what's called oblique astigmatism. This will be mentioned in the optical aberrations. There will be some problems with the lens design and the material. So the glass lens is thick and heavy, and the plastic lens is liable to scratches. So these are the main problems with each type. If we put a +13 or +14 diopter lens, which is made of glass, it will be very thick over the patient nose and heavy and disfiguring, and the plastic lens will be more liable to scratches. And if there is any changes in the back vertex distance, the patient will not be able to tolerate it. Cosmetic, as the patient will also suffer from the bad appearance or disfiguring appearance of the eyes. As we said in the first slide of the lecture, we said that the eyes appears very large, and usually if they are children, they will get mocked at in the school, saying that your eyes are very large. So this will be disfiguring to the patients and parents. Also, other problem with the spectacle correction of aphakia, that the anisoconia, that both eyes will have different retinal image size. So the emmetropic eye will have normal image size, while the eye with spectacle will have large image size or cause relative spectacle magnification of about 30%. Thank you very much. It was a long lecture, I know, and I hope that you understand it, and I hope that you find it useful during your study, and that you will be able to study it more and more, because it has a lot of information. So you need to study it very well, and it has one of the most important lectures in the optics, that many questions in the optics in the exam will come from it.